So, good afternoon, colleagues. Thank you so very much for making the time out of your very busy schedules to join the webinar this afternoon. We're really very excited that you were able to make it. My name is Foyeke, and I work with USAID Nigeria as a program manager for social behavior change. So I'm pleased to open this webinar today, and I would kick us off by just running through very quickly 3 major items. So first, I would give us a rundown or sort of overview of both Breakthrough Action and Breakthrough Research, which are both USAID flagship activities in Nigeria for social behavior change. Then I would tell us a little about what to expect on the webinar today, and then I will introduce our presenters and hand over to them. So first off, like I said, I manage as a social behavior change manager in USAID Nigeria, I manage 2 USAID flagship activities, Breakthrough Action and Breakthrough Research Nigeria. As the name implies, Breakthrough Action is our implementer of programs. So they apply all of the existing evidence, all of the tools, and all of the policies that exist, and design, implement, and monitor, social behavior change programs that aim to increase the adoption of a range of maternal, newborn, child health, nutrition, malaria, and family planning behaviors across 11 states in Nigeria. While Breakthrough Research takes the lead on implementing all of our operations, implementation, impact evaluation type of research activities to generate evidence on program and cost effectiveness that continues to inform learning and adaptation of our programming in country. So we're here today because one of Breakthrough Research's in-country research undertakings is the Behavioral Sentinel Survey, which will be conducted in 3 waves, so annually over 3 years, and tracking a cohort of pregnant women and women under 2 who are directly exposed to Breakthrough Action programming. So most of what you will be hearing today will be results from a baseline Behavioral Sentinel survey that's focused on 3 out of 11 Breakthrough Action states, and you'll be hearing more details about that. So while the primary purpose of the BSS itself is to continuously learn and adapt our programming, we definitely realize the importance of the data and the rich evidence that it has generated for broader application to programs, to policies, and even funding decisions. Which is why at about this time last month, and even prior to that, Breakthrough Action led a webinar to provide quick highlights of the results from the baseline BSS overall. And over the next few weeks, starting today, there will be a deeper dive into specific health areas. So today you will be hearing a little about Breakthrough Action programming, the BSS methodology, but really would be a deep dive into the results from an analysis of the relationship between what we call ideations or determinants of 2 behavioral outcomes, which is pregnancy and antenatal care attendance and pregnancy, as well as childbirth attendance or childbirth. So without further ado, I'm happy to introduce us to our presenters for today. We have Dele Abegunde, who is the Chief of Party for Breakthrough Research Nigeria. We have Temitope Ugubi, who is an acting Deputy Project Director for Malaria and TB on the Breakthrough Action Nigeria project. We have Paul Hutchinson, who is one of the principal investigators on the BSS and is with Tulane University. So Tulane University is one of the primary research partners on the Breakthrough Research Consortium. Also to say that the consortium in itself is led by Population Council. And finally, we have Emily White Johansson, who is the Deputy Chief of Party for Breakthrough Research Nigeria. So to encourage us to really pay rapt attention to the very interesting results that we're about to hear, and as much as possible, drop your comments, drop your questions in the chat box as the presentation progresses so you don't forget them. Over to you now, Dele.
Thank you very much, Foyeke, for that introduction. That's quite well appreciated. Without further ado, in the next 1 hour or so, we'll be going through the psychosocial influences around pregnancy and childbirth in the 3 states that we're focusing on in Nigeria, Kebbi, Sokoto, and Zamfara. In this webinar, out of the series of webinars, we will be taking you through with giving you an overview about the breakthrough research and breakthrough action, particularly their Siamese twin-like relationship that also informs this work we are presenting. We will also exhibit what the behavioral Sentinel surveillance survey is and how we have expanded to speak to the additional issues around demand generation in these states in Nigeria, and also today we'll be focusing on pregnancy and childbirth. There are several other thematic areas. This is the second in the series, which is focusing on pregnancy and childbirth. There are others: vaccination, breastfeeding, malaria, sick child, that is still in the offering. For today, we say, how did formative research inform the BSS survey? We'll get to know that. Another thing is that what are the new additional metrics that is coming out that will inform programming and even policy in the northern part of Nigeria in the future. The key findings that we have analyzed and obtained from the BSS study, and also the implication of these findings to SBC programming in Nigeria. Finally, we will then also discuss the future work even from here on SBC in Nigeria and this data. Next slide, please. Just to give you a bit about breakthrough research. Breakthrough research is USAID flagship project for social and behavioral change research and evaluation in Nigeria. It's a five-year project which began in August 2017, and it's hopefully it will end. It will be concluded by July 2022. The activity started in January 2019, and then we established the office in September 2019, and we had hit the ground running since then. Like I said, we're in close collaboration with the sister project, Breakthrough Action, who is on the field implementing the social and behavioral change programs within these states, which we'll explain to you in a while. And we also collaborate with other IPs that have related interests. And if you can be looking out, if you see areas of collaboration as we present, we'll be very happy to take up the collaborative discussions with you. I want to invite my colleague, Temitope, to take it up from there and give us a little bit about breakthrough action itself.
Thank you very much, Dele. Like Foyeke had earlier mentioned, Breakthrough Action Nigeria is the USAID flagship social and behavior change project. Prime implementation is by Johns Hopkins University Center for Communication Programs. The Breakthrough Action Nigeria project is also a 5-year project which would end in 2022. Our overall results is to increase the practice of 17 priority health behaviors in the areas of maternal, newborn, and child health plus nutrition, as well as family planning and malaria. For intermediate results, our intermediate results are to increase the social determinants of priority health behaviors, to also improve SBC coordination and collaboration among USG partners. We also seek to improve SBC capacity of national and subnational public sector entities. Next slide, please. Yeah, so what we have here are our priority behaviors. Remember, we said we have 17 priority behaviors. The program focuses on different behaviors targeting audiences for the different life stages for which these priority behaviors have been categorized. Our life stages range from pre-pregnancy through 2 to 5 years of age. Priority behaviors of focus as per the various life stages, like we said, are all categorized from pre-pregnancy all the way to 2 to 5 years of age. So for instance, for pre-pregnancy, we will have the target audience being couples, getting them to use a modern contraceptive method, including the long-acting reversible contraceptive to avoid pregnancy before for at least 24 months after a live birth. And this continues, for the different life stages all the way to 2 to 5 years for the integrated SBC program. Next, please. Yeah, so Breakthrough Action Nigeria, we use a coordinated multi-channel approach to achieve our objectives. We have the community mobilization. Under the community mobilization, we have community social behavior change, where we leverage on existing community structures such as community volunteers, ward development committees, affinity groups, and other groups to reach the target audience. We also have the community capacity and sustainability approach, which seeks to transfer ownership to the communities and get them to be responsible for their health outcomes. Another approach we use is the mass media, where we use both the print and electronic media, radio and the print media to reach the target audience. Our mobile and digital approaches use both SMS and interactive voice response to reach a wide array of target audience. In order to improve ownership and sustainability at the community levels, we carry out advocacies to religious, traditional, and opinion leaders. We also have the provider behavior change approach, which seeks to improve peer-to-peer knowledge sharing and experience among health workers, and also to improve client-provider relationships at the health facility level. So the integrated SBC program actually has an umbrella campaign, which we tagged Abeshirinku, and that is what you see to the far right. Abeshirinku is actually a Hausa phrase which translates to glad tidings. The campaign has a culturally and emotionally resonant theme, which is designed to, unite all the project's social behavior change approaches. Currently, the Abeshirinku campaign includes a weekly radio drama that addresses, specific maternal, newborn, and child health behaviors with cross-cutting issues, which includes gender and spousal communication. Next slide, please. So, Breakthrough Action implements SBC programs in 11 states and the Federal Capital Territory for integrated SBC for malaria family planning and maternal, neonatal child health and nutrition. This is currently implemented in 5 states. 3 of the states have had the integrated approach ongoing for a while these 3 states are the ones colored in blue. We have Sokoto, Kebbi, and Bauchi, while FCT and Ebonyi are currently migrating to the integrated SBC approach. We also have integration of SBC approaches, talking of malaria and family planning, in 3 states. So these 3 states are the states we have, with the yellow and red stripes. This will include Oyo, Plateau, and Akwa Ibom states. The vertical SBC approach is currently being implemented in 4 of our states, and these states are the ones in yellow. We have Zamfara in the northwest, Nasarawa and Benue in the north-central zone, while we have Cross River in the south-southern zone of the country. So like you all know, Breakthrough Research will or is already implementing the BSS study in Kebbi and Sokoto, which are integrated SBC states in the northwestern parts of the country, and then Zamfara, where we implement the vertical malaria SBC program. Thank you. So I'll hand this over to Emily, who will take us through this next section.
Thank you, Dele, Temitope, and Foye. I'm Emily White-Johansson, the Deputy Project Director and Director of Research and Evaluation at Breakthrough Research in Nigeria. And I'm going to talk now about the Behavioral Sentinel Surveillance Survey, or BSS, in general, and then also our specific research results related to pregnancy and childbirth. So the main objective of the BSS was to assess the effectiveness of integrated versus malaria-only SBC on malaria, family planning, and maternal, newborn, and child health, plus nutrition, behaviors, and ideations. And this is among pregnant women and women with a child under 2 years in Breakthrough Action Program areas. The BSS measures many priority behavioral outcomes that was discussed in the previous slide, many of the same DHS measures that you find across malaria, family planning, and maternal child health. But importantly, it also measures psychosocial influences or ideations. Those are cognitive, emotional, social domains that are theorized as intermediate determinants of behavioral actions and decision making. And so the psychosocial metrics that we developed for each health area were derived based on Kincaid's theory of strategic communication and behavior change. And this theory posits that a pathway from exposure to communication activities, in this case, the mass media, advocacy, and community activities that Temitope described in his slides, go through, for the recipient, go through 3 ideational domains and 9 ideational subdomains that can then lead to changes in intentions and behaviors. So the survey questions were intended to measure as many of these domains as possible across all of the priority health behaviors. So if you figure that we have 17 core behaviors and 9 subdomains, that's a minimum of 153 questions to get a really comprehensive look at the drivers of all of these priority behaviors. Now, in reality, we had many more questions than that, probably over 300 ideational questions. And even then, it wasn't as comprehensive as we would have liked. But we had a trade-off between being comprehensive and risking respondent fatigue that would jeopardize overall quality of the survey. So just briefly for the BSS design, the main study population for the BSS were currently pregnant women and women with a child under the age of 2 years. These populations correspond to the main life stage focus on by BA programming, and specifically they focus on the priority 1,000-day window from pregnancy through the first 2 years of life, as Temitope described. We collected data in all 3 states, but the data are only representative of BA program areas and not the states themselves. And the baseline survey, the results of which I'm going to present upon, was conducted in September of 2019 with a midline and endline survey planned for the future. The study design involves both cross-sectional and cohort components, and to provide estimates of prevalence of behaviors and ideations over time, we will use recruited cross-sections of women with a recent completed pregnancy at these 3 points in time, baseline, midline, and endline. And we also plan to follow a cohort of women who were pregnant at the time of the baseline survey to document their 1,000-day window experience. There is also a quasi-experimental component in the sense that we're comparing geographies with integrated programming in Kebbi and Sokoto with those with vertical programming in Zamfara. The BSS included, the baseline survey included over 3,000 women who were pregnant at the time of the survey and another 3,000 women with a child under 2 years. And that's because we do have 3 arms to this study. So it is quite a large sample at this baseline period. And in the presentation today, we'll present both bivariate and multivariate analysis results. And for the multivariate analysis, I'll present the predicted probabilities of an outcome occurring based on mixed effects logistic regression models that were adjusted for socio-demographic variables such as household wealth, maternal age, maternal and spousal education, and maternal and spousal employment. And the final baseline technical report is now publicly available, and it's on our website at the link listed here. It includes a full description of the survey methods as well as complete descriptive results for over 500 indicators or so. This is also disaggregated and reported by state. I encourage really everyone to, if you're interested, to download the report to get a sense of the breadth and richness of the data we collected, not just for pregnancy and childbirth, but across malaria, family planning, and all the other health areas too. Now, Breakthrough Action had conducted, in its first year on the ground, conducted wide-ranging formative work, including literature reviews, focus group discussions, in-depth interviews that we really drew heavily on in developing the survey questionnaire. And these went into reasons for non-use of maternal health services, perceptions of ANC, perceptions of, giving birth in facilities, and all of this information taken together really helped us shape the questions asked in our survey, and this was done jointly with Breakthrough Action. Now, there are a lot of ideational metrics in the literature for the areas of family planning and malaria, but much less has been published in the area for maternal newborn child health, including pregnancy and childbirth that we're presenting on today, but in addition, pneumonia, diarrhea, immunization, and other health areas too. So there was a need to develop new ideational questions for the BSS. And just to say that it's really important to have this kind of information because in the theory of strategic communication and behavior change, ideational factors are so important as behavioral determinants and are the basis for investments in BA, both in Nigeria and globally. So it's important to test these underlying relationships between the ideational factors and behaviors according to this theory. And again, the questionnaire was developed jointly with BA. We got input from outside experts and from USAID colleagues. We tried to use previous research wherever possible, but again, that was limited for the maternal child health areas. And as I mentioned before, we had to ask a limited set of ideational questions across each health area, and questions were therefore prioritized based on their importance programmatically. In this slide, I present the ideational questions we included for pregnancy and childbirth. And for each health area, we tried to have at least one question for each specific ideational domain. For example, for knowledge, we asked, in your opinion, when should a woman go to antenatal care for the first time? And the results were coded for data analysis as those who provided the correct response versus those who did not. Another example for beliefs, we included the Likert scale statement. Pregnant women only need antenatal care when they get sick. And women were asked to either strongly agree, somewhat disagree, strongly disagree, or don't know, or say don't know about this statement. We also included questions in the emotional and social domains, including self-efficacy about their confidence in getting to a facility for delivery or for antenatal care, as well as their confidence in starting a conversation with their husbands about these services. In addition, there was questions on social influences, social norms, and their intentions to undertake these behaviors in their next pregnancy. So now I'll present the key findings in pregnancy and childbirth according to the SBC program priorities. This includes behavioral patterns, such as how frequently do respondents practice the promoted health behavior? What are key behavioral patterns by geography or sociodemographic characteristics? Knowledge and beliefs. Are respondents aware of the promoted health behavior? Or are there certain beliefs or attitudes that hold back progress in this area? Barriers. How do respondents view health services in the community? What are the main reasons for choosing certain treatment locations or for not using the service at all? Social influence in decision-making. How do health decisions get made in households? Who mainly influences women's decisions about whether to use these services? And finally, ideational relationships. And this is where we bring hold of this information across cognitive, emotional, and social domains into a regression model to look at the relationship between these ideations on the behavioral outcomes. And really, it's to identify what ideations should SBC programs target in order to maximize impact. So we'll first start with behavioral patterns, and what you'll see in this slide and the next slide is low coverage of attendance at ANC 4 or more times, as well as facility delivery, with only about a quarter of women attending ANC 4 or more times during their last pregnancy. And what you'll really see here is a really highly inequitable, low coverage, and it's very highly inequitable. And it's the same with facility delivery, that you get these inequities even within these poorest states within the northwest of Nigeria. And you also see this inequity within when you map rates out by LGAs in this area. You see high variation by LGA with some extremely low levels, particularly in southern Sokoto and Kebbi. So knowledge and beliefs. In terms of knowledge, there was low knowledge of ANC timing and vagueness about its benefits. Less than half of women knew they should attend ANC 4 or more times during pregnancy. Only 1/4 knew that women should initiate their first ANC visit during the first trimester or as soon as she thinks she is pregnant. And while most women could name at least one ANC benefit to herself, they were the vague benefits, to be honest, and few cited the benefits of preventing malaria during pregnancy or reducing risks from complications either during pregnancy or delivery. ANC myths also persist. 40% believe that pregnant women need ANC only when sick. A quarter believe only first-time pregnant women need ANC, and about a third believe it's better to use traditional providers than a health facility for ANC. And in terms of barriers, when we asked about health services, about a third, again, believed it's better to use traditional providers and health facilities for ANC. About half believe the health facility is the best place to deliver a baby, despite very low usage. Less than half are confident in their ability to get to a facility for delivery. But nevertheless, when we asked about their stated intentions for their next pregnancy, about half did say they intend to deliver in a health facility during their next pregnancy. We asked women who did not attend antenatal care or who gave birth in a facility during their last pregnancy about reasons for this non-use. And the most commonly cited reason was that it just wasn't necessary to go. In the case of facility delivery, 67% of women who gave birth at home or somewhere outside the facility cited this as their main reason for not having a facility birth. Another important reason was spousal opposition, although we didn't ask any further questions about the nature or reasons for this opposition in order to inform SBC programs, so that's a ripe area for future work. In terms of social influences, we asked women who besides themselves may influence their decision to attend ANC or go to a facility for delivery. And the majority of women reported their spouse or husband, again, underscoring the outsized influence of men on maternal health decisions. And even more importantly, when we ran the multivariate regression analysis, we see that spousal influence had a significant association with the use of both services. So women whose spouses supported or influenced their decision were 1.2 times and 1.6 times more likely to attend ANC 4 or more times and give birth in a facility. In addition, we also found health provider support was significantly associated with the decision to give birth in a facility. So, of course, in the earlier slide, we saw that very few women mentioned health workers as an influencer on these maternal health decisions. However, from regression analysis, those few women who did have health worker support or influence, they were significantly more likely to then give birth in a facility. The next series of slides will show the significant associations we found between other psychosocial factors or ideations and the use of these maternal health services. So in this slide, we show the importance of ANC knowledge on having 4 or more ANC checkups during pregnancy. Women who knew at least one ANC benefit were 3 times as likely to attend ANC 4 or more times. Women who knew she should go to ANC at least 4 times during pregnancy were twice as likely to attend ANC 4 or more times. And women who knew to initiate ANC in the first trimester or once she thinks she is pregnant were 1.2 times as likely to attend ANC. So clearly, having knowledge of ANC timing and benefits is very important. But what we show in this next slide is that it's not sufficient. Also, self-efficacy and beliefs about ANC are also quite important. Women who had confidence to get to a facility for ANC were 2.5 times as likely to attend ANC 4 or more times. And also women who held certain beliefs about ANC efficacy or health services quality for childbirth were significantly more likely to also attend ANC 4 or more times. And in terms of ideations related to having a facility-based delivery, we see again that knowledge, beliefs, and self-efficacy are critical for this maternal health service. So women who had confidence to get to a facility for delivery were 3.4 times more likely to give birth there. Women who believed the facility was the best place to deliver a baby were 2.6 times more likely to give birth there. And again, knowledge about total ANC visits needed in pregnancy and beliefs about health services quality were also significantly related to having giving birth in a facility. So I'm going to now turn the presentation back to Temitope, who will discuss the program implications of these findings and how BA may use these results for program learning and adaptation.
Thank you very much, Emily. So we're now going to be looking at what program implications the BSS survey findings have for programs generally, and looking at our program at Breakthrough Action Nigeria. So first off, from the findings, we need to target SBC programs to the poorest areas for the greatest behavioral impact. And it is for this reason that we generally have a mix of approaches that target communities based on their peculiarities. So for instance, in certain communities in the states where we work, most of these communities are media dark, and radio programs definitely will not reach this target audience. So for such communities that are media dark, the other approaches such as community dialogue meetings, compound meetings and community dialogues, as well as house-to-house visitations, definitely would serve better in those communities. Definitely from the findings, we now know that in the past, we definitely would assume that costs and distance to health facilities were the main factors mitigating against access to health services. But from findings of the BSS survey, we now know that definitely we'll need further research to elucidate the specific barriers among the poorest women, since the earlier held notions around costs and distance to health facilities have not really held. Secondly, tailoring SBC messaging to address knowledge, beliefs, and self-efficacy. We need to ensure women know when, where, and how many times to go for ANC during pregnancy. it will interest you to know that in our findings, apart from pregnant women not knowing the right time for a pregnant woman to, initiate ANC visits, even health workers have also been found to not have that knowledge about when a woman is supposed to first attend ANC. So, working with service delivery partners to ensure that both health workers are adequately trained around ANC services and when to initiate, as well as working with the community structures to provide adequate information to pregnant women around the fact that they need to start attending ANC visits at the clinics from 13 weeks or when they first experience quickening. There's also a need to emphasize ANC benefits for mothers and newborns, especially during healthy pregnancies. So we have community volunteers, moving from household to household, providing this information about the benefits both to the mother and the newborns. There's also a need to dispel misperceptions that it's not necessary to go to the health facility for ANC or for childbirth. In several of the communities where we work, these misperceptions still abound, and community volunteers are providing information around the benefits to both the mother and the babies. We also need to support women's confidence in accessing services through SBC and other interventions. So in this regard also, we have community volunteers and the community structures also providing adequate information that would build the confidence of women in assessing the services through all of these interventions. Next, please. Yeah, so in addition to all of this, there's a need to improve both the perceived and the actual health services quality. Basically, some of our programs like the Provider Behavior Change Initiative has really helped to address the issues of provider side service delivery issues. Also, we collaborate with service delivery partners to improve the capacity of providers to deliver these quality services, while for the client side, we continue to go through the community structures to provide information about the quality of services that are provided at the health facilities. Prioritize improvements in pregnancy and childbirth services for their potential multiplier effects with the downstream MNCH plus nutrition behaviors. We also need to support health providers significantly since the BSS findings show that the health workers significantly influence facility delivery. There's a need to work with the health workers through the service delivery partners to improve the quality of messaging to pregnant women when they attend ANC clinics, to get them to return to the facilities for deliveries. The BSS findings also show that, men they have a significant role to play in the decisions that are made by their wives or their spouses as regards childbirth decisions. So there's a need to work definitely with the local leaders, such as the advocacy core group. We have advocacy core groups in our integrated states who work closely with men groups to try to increase their knowledge around the importance of hospital deliveries and ANC attendance. So spousal support definitely is a key driver to women's use of maternal health services, and programs need to focus on the men groups, reaching them with appropriate messages that would improve or increase their knowledge around the need to utilize the services for safe deliveries in health facilities. Definitely more research is needed, to elucidate the male ideations to further improve SBC programming for various health programs. So I would at this point, hand over to Dele, who will take us through what comes next after all of this. Thank you.
So thank you to Bitokwe, and then thank you for Emily for that brilliant presentation, taking us through the results relating to pregnancy and childbirth. So after all of this, what is the next step? I just wanted to let you know that we have just cleaned a little bit to present to you. The data is huge. The results that are coming in it's also huge, but you cannot take all of your time to present even from this small window, pregnancy and childbirth. What's our next step with the Bss analysis? One is that we'll be conducting the analysis to inform SBC program adaptation and scale-up, not only in the states that BA is working, and our results informs programmatic adaptation from BA's perspective, but other programs in Nigeria now and in the future that may want to approach increasing demand for healthcare through modulation of ideations and modulation of positive behavior through modulation of ideation, the whole SBC gamut. We are at this stage preparing many manuscripts and research briefs for dissemination. We are already concluding with the research briefs, but also keeping our doors open for IPs who will want BA and BL to dig deeper in thematic areas that relates to their focus. We are now planning the midline survey. The Bss survey is baseline, midline, and the endline, going shoulder to shoulder with the program implementation of BA. We are now at the point where we are preparing to conduct the midline survey. When we conduct this midline survey, it will even make our work more robust in that we will have we see time series data that tells us how things are changing with the programming in the communities that BA is working, and how we can provide evidence to help them to improve their programming and their targeting. Also, we are now already presenting results by specific health areas in our webinars. We have presented ANC and globally. We have done brown bag presentation to USAID globally, and we are doing the Nigerian series. And today is the pregnancy and childbirth. As you will see, in the next 2 weeks, we will be presenting the results from the breastfeeding perspective. I hope that we all know that between August 1st and 17th is the Global Breastfeeding Week, and we have lots of interesting ideation and behavioral data to show. These are new metrics that we've not measured before that we like to show on that day. Vaccination will come after. Sick child care seeking, child care seeking and treatment will come in September 3, and then malaria, September 17, family planning, and again a cross-cutting theme. This is almost like a serendipity, because by the time that breakthrough research was interrogating the data, we see that this factor of inequalities is also relevant to how the factors we are studying expressed in the communities. And so we have stepped down to really capture it in a critical kind of analysis, and to see how it may also inform programming. Next slide, please. So we hope that you will stick with us on all of this presentation. Again, it's huge. We are just bringing little out to present to you. Now, what is the future significance of our work? These BSS baseline results are a first step for assessing the effectiveness and cost benefit of integrated versus malaria SBC program in Nigeria. And then it highlights the ideations and behaviors during the baseline period, because PA is now transiting to mid-program period. So we have captured the baseline period data to inform SBC program scale-up and adaptation. Of course, the data becomes even more robust when we have the midline data. Now, we present in this study, huge study, new additional metrics across maternal, newborn, childhood health, plus nutrition, and then we quantify their relationship with behavioral outcomes to test behavioral change theories. Also, this BSS results is linked with protein program data of all health facility records to examine the impact of supply on and demand side factors on service use. So we link them together. We just come short of doing probably an equilibrium analysis that tells us how these things link, but the level we get to will give us a lot of information on the link between the demand side and the supply side, and how modulating ideation to modulate behavior can improve health-seeking behavior in this team. Again, like was mentioned, I want to appreciate our PIs in Washington who give us a lot of support and supervision and direction on this project. Paul Hutchinson, he's a professor at University of Tulane, and Paul Hewitt also in population in Washington. Of course, Emily introduced herself to you in addition to Oyeka's introduction. And we have Elizabeth Omoluabi, who together with Professor Akone Akiemi, which some of you may have met before in CREC, they are collaborating with us very powerfully, but particularly on the field work aspect. They have applied innovative technologies that makes field work facile and improve the quality of the data that we have over what we'll have had if we have used the traditional method. Of course, me, I'm the chief servant in this presentation. We have Dominic Mikas, who is in the University of Tulane. These are the people who are working in the engine room of the data, crunching the data and making it to speak out its meaning. And we have Udo also, which I appreciate very much, is the research coordinator in Nigeria, Breakthrough Nigeria, and then Stella Balola. We also want to acknowledge Ian Tweedy, the country project director for Breakthrough Action, and Matthew Oko in BA, and Shitu also Abdul Agwe from Breakthrough Action. But more importantly, we want to appreciate every one of you that have made time to come and listen to us. As we go into the question section, we hope that you will interrogate these results with your questions. That will help us to also even fine-tune areas that we may have lacked rigor in. I will appreciate that, because your questions and interrogations will improve the results from the data. At this stage, I want to thank you, and we expect you again in 2 weeks' time for the breastfeeding webinar. We are sorry that a lot of people have signified that they had difficulty in linking up to this webinar. We will address it for the next webinar. We want to see all of you there. At this stage, we hand over to our activity manager in USAID, who has facilitated this webinar so marvelously, Foyeke Oyedoku, to continue from here.
Thank you very much, Dele. I think you already did a fantastic job of thanking everyone for their rapt attention, and I really just wanted to reiterate that. Sherry, I don't know, do we have questions that we would need to take, or were they all addressed in the chat box?
They were addressed in the chat box.
Okay. All right. So thank you very much. So I guess my work is easy then. If questions have been addressed, it's really to say, I'm not sure we have just 3 minutes left. I'm not sure if we have room to take one maybe verbal question, or maybe we just, is that even possible? Because I feel like people were muted.
They would just need to chat the question.
Okay.
So send it to me, the host, or to the panelists.
Okay. All right. So please, as initially proposed, yeah, we understand that. I mean, the concerns around difficulty of connecting and joining the webinar has been very well noted. I also have a couple of colleagues who couldn't join at all because they just had difficulties. So I feel, like Lily said, we would be thinking through how we address that particular problem before the next webinar on August 6th. So to say thank you very much again for taking the time to join, and I'm hoping that it was completely worth your while, and that you were able to at least, glean, maybe somewhat validate some of the things you already knew that were already applying to your programs, learned something completely new that you had no idea about related to these behaviors, and potentially unlearn some of the things that we thought we did know, but now the evidence is telling us otherwise. So thank you so very much again for taking the time. Sherry posted the link to the full report in the chat box. If you haven't, please copy the link or just click on it and download the full report so that you have a good sense of the wealth of data that's been collected through the BSS. Thank you, and we hope that you're able to join us on August 6th for more detailed conversations around the breastfeeding. Thank you so much to our presenters as well for a fantastic job. I guess we can all. So can you repost the link, Sherry? A few people are asking for it again in the chat box, and then we can close out finally.
Yes, I just did.
Okay. So thank you very much. The link has just been reposted. If you didn't get it before, you can get it now. And we again sincerely appreciate you for your time and look forward to our next webinar discussions on breastfeeding related behaviors in 2 weeks' time. Over. Thank you, everyone.